All right, I have 5 after, and I don't really see too many more people jumping on. So if it's okay with everyone, we'll go ahead and get started. So first off, my name is Jason McNair. I'm a family physician and the chief of staff at Mon Health Preston Memorial Hospital up in Kingwood, West Virginia. And today we're going to go ahead and talk about social determinants of health and a value-based care approach. So before we jump into the nuts and bolts of the presentation, let's think about a story. We have 2 patients, both the same age and gender, who wake up going about their morning routines when they notice a sudden numbness in their right arms. Rapidly, that's followed by weakness, and they're both lucky enough to have their spouses around to notice the changes, who call 911 within minutes of noticing those changes. And as you're going to see in a couple seconds, this is where the story diverges for the 2 patients. And these are going to be the things that I want you to kind of think about as we move through the presentation. So we have patient A. He's a 55-year-old gentleman who dropped out of high school and is working as a coal miner, but he just discovered that his mine was going to be closed, and he's really uncertain about what his future employment is going to look like. He lives in a rural West Virginia town. There aren't really any grocery stores nearby. He's got to drive at least 30 minutes from his home to find a grocery store. He doesn't regularly see a physician, and he oftentimes seeks care from his emergency department. And even that's located about a half an hour from his home. Now, he is involved in his local church and has a support network there, but he speaks very little English as a second language. Now, compare that to patient B, who is a 55-year-old college graduate with an MBA. He is working as a CEO at a tech firm, and he lives in urban West Virginia. And he is within 5 minutes of several grocery stores. He follows regularly with his doctor, and he's within minutes of a major healthcare system and hospital with advanced care. He's pretty engaged in his community, he volunteers regularly, and he speaks English as his first language. So before we move on, the things that I think are really important is that we put this into perspective, because when we think about social determinants of health, sometimes it's easy to say, how important is that when we have all of these great healthcare advances? Well, when we look at a statement from Daniel Knecht, who's a doctor that works with CVS Caremark, in an interview that he was talking about genetic medicine, he said, your zip code is more important than your genetic code as it relates to health outcomes. It's exciting to focus on genomics and its promise, but at the end of the day, the bigger driver determinant here is the social behavioral determinants of health. And to kind of push that a little bit further, the World Health Organization estimates that social determinants of health actually account for 30 to 55% of health outcomes, so certainly not a minority. So today we're going to talk a little bit about social determinants of health. We're going to define that, and we're also going to define what value-based care is. We're going to look at different categories and examples within each of those categories of social determinants of health. And then we are going to use some examples to look at how that affects health outcomes, how it factors into health outcomes. And then we're going to discuss screening and screening tools, talk about documentation, and then come up with some plans to utilize these in our practices to help with the outcomes of our patients. So I think we all probably have a pretty good idea about what value-based healthcare is, but at its core, it's care that is patient-centered, focusing on improving results and quality while we're also decreasing costs for the system. In order for this to be truly effective, it has to have a few core components. It has to be accountable. When I say that, I mean it has to be patient-centered, where a team takes responsibility for improving the care of the patients, for doing things like coordinating the care, making sure that the outcome goals are met. And when we're talking about care or coordinating care, we're making sure that we're helping a patient interface with a pretty complex system. We're helping them navigate the medical system because, as we all know, it's not necessarily easy to do. On top of that, it has to be integrated. We can't just focus on what single thing we are seeing a patient for at a visit. Otherwise, we're going to neglect things like their mental and their social needs in addition to their physical needs. And then we have to make sure that it's patient-centered. We've got to focus on bringing our goals into alignment with the patient's goals. And by doing those things, that's how we're going to reach the optimum outcomes for our patients. So social determinants of health fits pretty well into this value-based system. And I think that there are a few definitions, all with the same backbone. The CDC defines social determinants of health as the conditions in the environment where people are born, live, learn, work, play, worship, and the age that affect a wide range of health, functioning, and quality of outcomes and risk, or quality of life outcomes and risks. The World Health Organization goes on to give a little bit broader definition, saying that there's a wider set of forces that shape the conditions of daily life that include economic policies and systems, developmental agendas, social norms, social policies, and then political systems. So if we're thinking about government and healthcare policies, those oftentimes have a great impact on health and how we can deliver healthcare. So that's just an easy example within that realm. So now let's get into kind of what we classically think of as the social determinants of health. When I'm presenting these, I like to think of them kind of from a starting point. And I think oftentimes the starting point is education. Education really is a predictor of economic stability. Those who are educated and able to achieve well-paying jobs are going to be set up to meet the remainder of their social and economic needs, and therefore help drive positives for social determinants elsewhere. So it doesn't just include that though, but we're also talking about like language. Are we able to understand the language? Is there early childhood education available, both for the patients, but then also for their children, so that we can start to try and break a cycle? Is there vocational training for patients, so that if they aren't someone who is going to go to a traditional college route, that we can find things that meet their needs and help them to succeed within the system? So then we go into the economic stability, and this is where I think everything else kind of branches from. But economic stability is talking about things like the employment, the income, and then what are our expenses within the community? Are we able to even afford to seek medical care? And then what kind of support do we have from our community and from those that we care about? So from here, we go on to, I think, neighborhood and physical environment. So housing, transportation, safety. And when we think about the neighborhood environment, we can't just think about what's the house that they live in. Like, we have to also think about, like, do we have transportation? Because if we don't have transportation, we cut off a lot of our other means of achieving these social determinants of health. Are there sidewalks? Can patients walk to stores? Can they walk for exercise? Are there playgrounds where kids can be outside and play safely? And then when we think about the housing, is the housing safe? Is it somewhere that doesn't have mold that is going to drive down their overall health status? Is it safe from, like, being in a neighborhood where crime rate is high? All of those things are important. And then food is obvious. If someone's worried about whether or not they're going to be able to feed themselves, medication takes a pretty low seat on that totem pole when we're talking about what do we want to accomplish. But on top of that, even if they can afford food, can they afford healthy food? Is there access to healthy food? Because we oftentimes live in food deserts here in West Virginia, where the foods that are available just aren't the ones that we need. And then there's the healthcare system itself. And this is another one that I think oftentimes we think about, but don't think about in depth, because the obvious things are like, do patients have coverage? Do we have insurance? But we also have to ask the question, are there even healthcare facilities or healthcare providers to meet the needs within an hour, within 2 hours? I mean, we live in a relatively rural state, so we don't have specialty care close to everyone. We don't have rehab close to everyone. We don't have dietitians. Like, so many services that we think of when we're talking about comprehensive care, and that's not even to mention the mental health aspect of things. And all of this is operating within the community and social context. So everyone has stress in their life. Everyone has some degree of support systems or a lack of support systems, and they're integrated in different ways into the community. And this is shaping all of those because those stresses and supports are what help us either meet or make those needs harder to meet. And then everything that we just talked about factors in to health outcomes. So when we are looking at how an individual disease process may look in this context, I thought it was helpful to kind of come up with a flow chart that we could kind of feed a disease process into and look at, well, how could each of these individual social determinants affect it? So I picked type 2 diabetes because I think that's something that we all see pretty routinely, and it's something that has a huge, or that social determinants really do have a huge impact on. So when we're thinking about education, if someone's well educated and can understand the instructions that you give them at the visit, have a good understanding of medical terms, then communicating to them our needs in terms of taking care of their diabetes becomes relatively easy. However, let's take it to the other extreme. If you have someone who can't read well, someone who maybe doesn't understand our instructions, doesn't understand an insulin titration schedule, that is certainly going to make care for them more difficult. And also, it's going, if we have someone who's not well educated, they're very likely to have a lower income because of their employment opportunities. And then we think about employment in its traditional sense of generating income, but in type 2 diabetes, the type of employment that someone has is going to affect their ability to exercise. I take care of a lot of folks who drive trucks who are in a truck for 8, 10, 12 hours a day. And when they come back and see me, we ask, did you exercise? And they said, no, I was working all day. I drive a truck. Unless you count climbing in and out of my truck a few times a day as exercise, and that doesn't really count. So then we think about the neighborhood, and we talked a bit about, are there sidewalks, are there playgrounds, are there places to get outside and safely exercise? If those things are present, it makes it easier to help to generate an active lifestyle. It helps to exercise down blood sugars. But if they're not present, it then becomes incumbent upon them to drive somewhere or to have a treadmill or something else that they maybe just don't have the means to do. And then food is obvious in diabetes. The ability to obtain food, the ability to have healthy food. It's impossible to treat diabetes if we don't have consistent healthy food. I mean, for instance, you may have a patient who one or 2 weeks out of the month, when they're paid, have the ability to get some healthier foods. But what about the other 2 weeks? So we have great sugar control for every other week, and then we have terrible sugar control, and it's not through any fault of their own. It's just the reality that they live in, and we have to figure out how we can intervene on that. And we had talked a little bit about the healthcare system, and I was alluding to the diabetes educators. They're pretty rare. They're hard to find. Even within Morgantown, there aren't an abundance. So getting folks into those sectors is important. Having the ability for them to see an optometrist or ophthalmologist, to have their diabetic eye screening completed. And then, God forbid, we start to have complications such as renal disease, we have an even harder time finding that specialty care. So the healthcare availability becomes a huge issue. And all of that weighs into their A1C, their weight management, the cardiovascular health. And as I'd said before, all of this is happening within the social context. Is there public support? Are there policies being made that make it easier for them to have these needs met? And what are their stresses that they're dealing with in the day-to-day life? So none of this works within a silo, and they're all interconnected. You can't talk about food without talking about the neighborhood in which they live, because that helps determine where groceries are. You can't talk about food without thinking about income. And you can't talk about healthcare without, so there should be a lot more arrows in this chart, but it would have become too confusing had we gone that route. So we talked a lot about how important they are in social determinants are in disease processes. How do we screen for them? What does this look like? Well, there are a few different tools. Two of the most common tools that I found that were substantiated were the CMS Accountable Health Communities tool, as well as the protocol for responding to and assessing patients, assets, risks, and experiences, or the PREPARE. And the PREPARE is, I think, what we're using more commonly. And that looks at a few different things. So first of all, it's looking at demographics. So race, ethnicity. We're looking at family and home, as well as what resources they have available. And then we're looking at social context. And it's a two-page screening tool. It can be administered in the office. It can be administered prior to the office visit, and then they bring the paper in with them. If you're lucky enough to have this integrated into an EMR that can pull it into your chart, that's the ideal, because then we start to have a better ability to collect the data. So speaking of collecting data, how do we document what we find? So on the prepare form, there are, as I said, all those different categories, and positive screening will necessitate a little bit more digging. And there are Z codes that are available now through CMS to help us kind of identify those needs better. And Z codes are codes that refer to factors that influence health status or contact with health services that aren't classified elsewhere as different diagnoses. So we have Z255 through Z265 listed that go through a whole litany of social determinants, from health and literacy problems to problems related to employment or unemployment, occupational exposures, problems related to physical environments, housing, problems related to upbringing are on there as well. And then there are even more specific Z codes underneath of the broader categories. So why does this all matter? We're going to get to the bigger why later, but for the quick and dirty of checking the boxes from CMS, we're currently measured on 2 quality metrics for inpatient medicine. And currently the 2 measures that are being required to be reported are, first of all, what percentage of patients who we admit to the hospital who are 18 years or older are screened for social determinants of health. And second, what percentage of those who are screened positive in those 5 major areas. Specifically in inpatient medicine, homelessness will increase a fee-for-service reimbursement within hospitalized patients. If the goals that are identified, or if the social determinants needed and identified are then addressed in a comprehensive discharge plan. So that's the goal there, is we identify homelessness and some of the other social determinants of health where we have an opportunity to improve. We then intervene, decrease the risk of readmission, and should be reimbursed at a better rate. On the outpatient side, there's not currently a quality indicator, but CMS has said that they will reimburse for a comprehensive screening up to every 6 months. And it's paid in full if it is done as part of a Medicare wellness examination. The expectation, of course, is that there's a link between the social determinants of health screening and a disease process that the patient has, because screening just to screen doesn't necessarily make a big improvement. When we're reporting this, it's a G code G0136, and I think that's reimbursed at around $18.66 per patient. Using the data. So this is where I think we start to have a broader, more important look at why we're doing this. So we've already identified like what are Z codes. We've talked about how do we collect them, and why we collect them is because 30 to 55% of healthcare outcomes are related to what we find. And then we have kind of a individual level and a population level benefit to collecting them. So at the individual level, it's a pretty obvious benefit. If we find a need, we can intervene, help the patient meet the need, and then improve the healthcare outcomes for that patient. Someone needs transportation, can't make it to any appointments with a specialist that we arrange because they don't have a way to get there, and we intervene and help them get to those appointments. Obviously, healthcare is going to improve for that patient. But equally and possibly more important is that it starts to allow us to see gaps within our community. So what we're doing by collecting this as a healthcare system is identifying gaps in our network. And we're going to start to see things like food insecurity, housing insecurity, and transportation insecurity as three of the leading things that are identified. And that's not necessarily unique to West Virginia. When we look nationally, those are three of the biggest needs that we have. And what this allows us to do is it allows us to plan. It allows us to create policy to start to address those things. It allows us to invest money into helping to meet those needs for our patients. Because if we don't know what our needs are, we can't meet them. So ideally, if you this is just another illustration of the slide before, but ideally we have an EMR that is going to be able to help us do this, so that we can extract data and identify those needs, talk about funding decisions and policy decisions, and then really make an impact on our community. This is all a lot though. We have 15, maybe 20 minutes if you're lucky, per patient visit in our day. And how do we do all this as part of that when doing a comprehensive screen can take anywhere between 5 and 15 minutes? Then we have to think about, well, who's going to review the data, who's going to put it in the EMR, and what about resources? I haven't even talked about resources yet. How do we find those? And then where do referrals come from? How do we follow up on those referrals? And those are all tough questions. So I'm a big advocate for a team-based approach to care. If I, as a physician, am trying to do all of this and meet every need, I would not sleep and still not get everything done that I needed to. But when you involve a team, and what that looks like is engaging the patient as well as all the members involved in patient care, including your medical assistants, your clinic nurses, CCM nurses, population health nurses, and engaging them to the fullest extent of their education and licensure to allow them to focus on meeting the needs of those patients. That's when we're going to start to have some time and have some overlap in our capabilities to meet the needs. So if we are talking about screening, I think that having a pre-visit phone call to let them know that this is coming, and having as part of your check-in, handing out the prepare form so that we can at least do that once a year with a wellness visit. And then as far as looking at those, ultimately it is going to be the physician's responsibility to enter the diagnoses into the chart. But this is where, once they're identified, I think that we have the ability to utilize our supporting roles and supporting positions within the clinic to make these things happen. And locating the resources, as originally I thought one of the most challenging parts, but I found some tools in preparing this that are actually pretty helpful. So West Virginia 211, it's something that I did not know about. It is West Virginia, or wv211.org. If you type that in, you're going to come up to a home screen that looks like this, and then scroll down further and you have this, excuse me. And so all it's saying is you can call them, or you can chat with them or text, and you're going to have a specialist who is there to help you understand what resources are available. It's housed within 10 United Way offices throughout the state. There are care coordinators who are present. So back to the first screen that you go to, let's just run through an example. If we're trying to find food resources for one of our patients, so we would click the find help. That's the bottom. We'll skip that page. And then we have basic needs. Then we go to food. And I utilized my zip code in Kingwood, West Virginia. And these were the resources that came up based upon proximity to my location. And there was a page, I think 10 to 15 long of resources. So let's go back to the patient that we had talked about at the beginning of our presentation. So patient A, he's having a stroke, obviously. He didn't graduate high school. Maybe he didn't know what signs of a stroke were. Maybe he didn't know about the about his underlying health care, and he was more likely to have a stroke because of that. Now he's losing his employment. We don't know, will he have insurance going forward? How is he going to meet his needs for his family? How's he going to meet his needs for himself? And then he's got a lot of cards stacked against him. He doesn't live close to anything. He has poor transportation. He can't, there's no walkability. So if he comes out of this stroke needing a wheelchair or something, he's going to need ramps into his house, or he'll need other handicap accessible modifications made. He doesn't have fresh food, so it's going to be harder for him to rehab and get the caloric and nutrient needs that he has. And then he very likely doesn't have a rehabilitation hospital near him. He probably didn't have an ambulance immediately available when he had the stroke. Some communities have one ambulance in the whole community, and if that ambulance was busy taking someone somewhere else, who knows how long he had to wait until an ambulance was available to pick him up, get him to the hospital. He maybe wasn't even inside of the realm of having any thrombolytic therapy. And then, was the hospital equipped to handle that even? These are all questions that are affected by where he lives and how he lives. And then, was he able to communicate his needs? We had already talked about him having English as a second language. Did he face discrimination because of this? We know he's under stress because of all of the social and economic challenges that he's facing. Now, he did have some positives in the support from his church, and churches are oftentimes a great source of support for our patients. But we need to do better as a profession in helping them as well. Whereas when we compare him to patient B, pretty much everything that we had talked about was in opposition to patient A. He's educated. He lives in a urban community. He has a good job with stable income. He has all of his basic needs met. He's able to get fresh foods and go to fresh food markets. He's able to have immediate ambulance service. He has advanced stroke care. He has rehabilitation, inpatient and outpatient physical therapy, all available easily to him. He has support from the community organizations that he's working within. He's well connected. There aren't any language barriers. So just from a navigation standpoint, he had less issues just navigating the healthcare system. He was able to get there quicker. He didn't have barriers in communicating. So this is where we come in. We've learned how to screen for these social determinants, and we now have a tool where we can start to look at what are some of this patient's needs and figure out how to intervene. So in the context of an acute event like a stroke, maybe the education doesn't apply, but prior to him having a stroke, once he found out that the mine was closing that he was working in, if he's following with one of us regularly, we're able to say, well, here are some resources for vocational tools, because there's a whole section within that West Virginia 211 that talks about different education resources. And then we have the same for financial assistance programs. There are many financial assistance programs that range from needs such as utilities to food to meeting mortgage requirements, all with varying requirements. And it takes a little bit of legwork on the patient's part, or if you're lucky enough to have a social worker within your clinic, that's something that they can also help out with. We know that he may have some difficulty with transportation, especially if he requires any specialty transportation to get to appointments. So there are medical transport services available that you can identify within that network of resources. And there are food pantries that we can help them find. And then there's also an area where we can find different healthcare systems available and different different rehab hospitals, different therapy offices. All of that is available within West Virginia 211. And if there's something that we're looking through, clicking, and can't find, we have the ability to call one of their specialists who's going to be able to at least help us think of some outside of the box answers and solutions for that patient. So we're not fixing everything. It's far from that, but we're evening the playing field just a little bit. And if we start to even the playing field just a little bit, we get a lot closer to health equity. So most of my resources for the talk came from CMS.gov, the World Health Organization, Kaiser Family Foundation, Prepare Screening Tool. And just as a final thought, I'm a big fan of William Osler. The good physician treats the disease. The great physician treats the patient who has the disease. And by intervening on these social determinants of health, we're doing just that. We're identifying and intervening for the patient to help them take care of their disease. So that is all I have for this afternoon. Are there any questions, thoughts, or feedback?
Thank you, Dr. McNair.